Hi, I'm Michael Betel, President and founder of the Fatty Liver Alliance, and I'm here with my very good friend Naim Alkhouri, Chief Medical Officer at Arizona Liver Health. And this is going to be an incredible hour together today. Why? Because we're following up on the AASLD TLM 2024, which was a phenomenal meeting in San Diego with so much information shared and new updates. And it's really an incredible time to be alive in the MASH space. Am I right, Naim?
Absolutely. Always good to be with you, my friend. It was an incredible meeting, very empowering to see all the new developments. And I want to thank you for hosting this and also thank Sonic Insights for sponsoring this webinar.
I'm looking forward to what we're going to discuss. So I guess over to you.
Thank you. My goal over the next few minutes is to provide you with the key takeaways from the liver meeting, insights into the future of liver health. As you guys know, 2024 was a historic year for us in the steatotic liver disease space. Specifically for MASH, we had the first FDA approval of resmetirom in March. And this was indicated for patients with MASH and F2, F3. And this really changed the dynamics in our clinics and how we approach treatment for our patients. At the liver meeting, I think the biggest news was the positive results from the Essence phase 3 trial with semaglutide, and I'll go over the results in details. And in 2024, my mantra was just do something. And this was true for primary care physicians, endocrinologists, gastroenterologists, and hepatologists. And the something is the three S's. S number one is to screen for steatotic liver disease in high-risk groups, such as patients with type 2 diabetes and metabolic syndrome. We are spreading the word out into PCP offices and endocrinology offices that in 2024, you have to be actively looking for MASLD and MASH. Once you identify that the patient has steatotic liver disease, the second S is to stage fibrosis and know if they have MASH with F2, F3 fibrosis, because we can treat these patients now. In addition to clinical trials, resmetirom is FDA approved, and we can do this without needing a liver biopsy. And the third S is once you identify patients with MASH and F2, F3, to start treatment with resmetirom, also optimize diabetes and weight loss management with GLP-1 agonists, semaglutide, tirzepatide. So we can do a lot for our patients in 2024. So first, I want to start with sharing some data with semaglutide. These are the results of the phase 3 Essence trial. Again, patients with MASH and stage 2, 3 fibrosis. These patients were randomized to semaglutide, the obesity dose, so dose escalation up to 2.4 milligram weekly versus placebo. Again, all patients had MASH with F2, F3 on baseline biopsy. They're treated for 72 weeks, and then they had a second liver biopsy. The two primary endpoints were MASH resolution and fibrosis improvement by one stage. These are the baseline characteristics, so very typical for a MASH population, middle age, high prevalence of type 2 diabetes, and you can see high BMI. I highlighted the non-invasive test measurements here, so you can see how a patient population with MASH F2, F3 would look like based on NITs. And you see the liver stiffness, transient elastography, kilopascal was at 12.8 average. The enhanced liver fibrosis score was around 10. Another biomarker for fibrosis called ProC3 was around 53. And these are the primary endpoints from the Essence trial. And this was, I would say, in my mind, was the biggest news at the liver meeting. So semaglutide achieved both primary endpoints in terms of MASH resolution. You can see it was achieved in close to 63% with the 29% delta from placebo. So the absolute risk reduction is about 29-30%, which means that you need to treat three patients with semaglutide for 72 weeks to achieve MASH resolution in one, which is a very good number needed to treat in medicine. More importantly, in my mind, semaglutide achieved also the improvement in fibrosis by one stage in a significantly higher percentage of patients than placebo. This was achieved in 37% with semaglutide with the delta of 14.5%, which indicates that you need to treat about 7 patients to achieve fibrosis improvement in one. So in the phase 2b trial with semaglutide, there was no signal on fibrosis improvement. So it was very encouraging to see this in a large phase 3, establishing that GLP-1 agonists can actually reverse fibrosis in a percentage of patients. And then we looked at other endpoints, including change in body weight. And as expected, there was weight loss with semaglutide. There was also a significant number of patients that achieved both MASH resolution and improvement in fibrosis. And very importantly, also, there was improvement in quality of life measurements. So patients felt better on semaglutide compared to placebo. There was also a signal on improvement in liver enzymes, ALT, AST, gamma GT, between 30 to 40% reduction. And this was actually sustained throughout the trial. So this is very encouraging because in our clinics, we follow the ALT, AST very closely. And then we also saw improvement in non-invasive tests, including liver stiffness on transient elastography, reduction by 20%, reduction in serologic biomarkers for fibrosis as well. So overall, very good news for our patients with MASH, F2, F3 fibrosis. We've known that semaglutide has beneficial effects in terms of weight loss and improving A1C and preventing cardiovascular outcomes. And now to see that it works on both MASH resolution and fibrosis improvement is very encouraging. Moving on to resmetirom, the thyroid hormone receptor beta agonist that was again approved in March of this year. We've seen the results of the Maestro-NASH trial published in the New England Journal of Medicine a few months ago. This was the trial that led to the accelerated FDA approval. Patients were randomized to placebo, resmetirom 100 or 80 milligrams daily, and they had biopsy at baseline showing MASH with fibrosis, biopsy at 52 weeks, and they looked at the same endpoints, MASH resolution and fibrosis improvement. These are the baseline characteristics, again, just showing the non-invasive test data, very similar to what we saw in the Essence semaglutide trial, liver stiffness around 12, consistent with significant fibrosis, ELF around 9.7. So this is nice to see that throughout these clinical trials, the NITs are performing similarly. And these are the results, and this was again published in the New England Journal of Medicine. You see the NASH resolution rate with resmetirom, 100 milligrams at 30% with the 20% delta from placebo. We saw 29% delta from placebo with semaglutide, but this was with longer duration of treatment, 72 weeks versus 52 weeks with resmetirom. And also resmetirom hit on fibrosis improvement. You see with the high dose 100 milligrams, there was improvement in 26% with the 12% delta from placebo. And again, this is with the shorter duration. So in my mind, efficacy-wise, both medications are comparable. You can't really compare apples to apples because different inclusion, exclusion criteria and different duration of the trial. But this is very encouraging for our patients that now we have two medications proven to work on both endpoints in large phase 3 trials. At the liver meeting, more data were presented from the Maestro-NASH program, and we looked specifically at patients that were on a baseline GLP-1 therapy. So they've been on a stable dose. They're not in the active weight loss dose. All these patients in the Maestro-NASH had diabetes, and they're on the previous diabetes dose with the max of 1 milligram weekly. And some patients were on other GLP-1 agonists. When we compared patients on a GLP-1 therapy monotherapy, which was around 15% of patients in mice with NASH, to those not on a GLP-1. The GLP-1 users were all diabetics. They had more F3 fibrosis, and they showed no difference in baseline MRI PDFF, but they had more metabolic and cardiovascular features, and they're more likely to be on a statin medicine. I think the key takeaway from this trial was that being on a baseline stable GLP-1 or not did not affect the response to resmetirom, whether it was the MASH NASH resolution rate or fibrosis improvement rate. So this study provided us with evidence that if you add resmetirom in a patient on a stable dose with GLP-1, that you're going to see added benefit on both the main endpoints, MASH resolution and fibrosis improvement. So we expect that in 2025, we're going to have two FDA-approved medications, resmetirom, which is already approved, and hopefully semaglutide by the end of 2025. And I don't think this is going to be a fight. This is just, for the visual effects. I think actually there's a lot of synergy between the two drugs. But I think, we have to decide which one we're going to start first. And in some patients, we may be okay just utilizing one agent and you don't need both of them. But I'm pretty confident that in a sizable percentage of patients, you may need both medications, especially to achieve fibrosis reversal in the F3 population. So when we decide on how to select patients for treatment with resmetirom, and I suspect we will use the same criteria for semaglutide, we have this consensus paper that was published by an expert panel looking at different non-invasive tests. And I underlined transient elastography because this is the most common way to qualify patients for treatment in the real world. And these are the data based on the FibroScan machine, but liver stiffness can be measured with different machines, and we will discuss the VelaCure machine later on. But the key is that this is, again, available. It can be done as a point-of-care test, and you can make a treatment decision when you see the patients. And we divided patients into 3 zones based on their non-invasive test. We have the green zone. We call it the sweet spot, where it's a clear indication to treat and you're not worried about them having too early disease or too advanced disease with cirrhosis. And if you look at transient elastography, it's between 10 to 15 kilopascal. We also established the criteria for MR elastography, enhanced liver fibrosis test, and other NITs. And then we have the red zone, which is do not treat. So these patients are very likely to have cirrhosis, and we know that resmetirom is not indicated for cirrhotic MASH, and the same will be true for semaglutide. And then in between, we have the yellow zone. These are patients that have NITs that are borderline. So some of them will have cirrhosis, but the majority of them will actually have F3 fibrosis based on some data that we shared at another liver meeting. So these are patients, for example, with transient elastography between 15 to 20. You need to do due diligence, make sure they have a normal platelet count, obtain imaging of the abdomen showing no splenomegaly, that the liver has a smooth contour. You may calculate other scores like FIB4 or maybe obtain an ELF score. But once you make sure that they don't have cirrhosis, then these are patients that you can treat with pharmacologic treatment. So this is how we select patients for treatment today. And, based on these criteria, I want to show you how we may decide which treatment to start first. So the first case is a 53-year-old male with past medical history of hypertension, obstructive sleep apnea, knee osteoarthritis, and a BMI of 39.2. So multiple comorbidities related to obesity, comes with incidental finding of enlarged liver on ultrasound, and the FibroScan liver stiffness was at 11.6 kilopascal, which is consistent with F3 fibrosis. It is important to note that with different machines, sometimes these cut points for the fibrosis stage may vary. So make sure you familiarize yourself with the cut points based on the machine you use, if it's FibroScan versus VelaCure. And the CAP score for steatosis is consistent with severe steatosis. So I selected to start semaglutide first in this patient because we can induce weight loss and improve the obesity-related complications. And now, based on the ESSENCE trial, we know that there is a chance it may help with fibrosis improvement. I will treat with semaglutide for a year and then I repeat my fibrosis assessment. If fibrosis is heading the right direction, I would continue semaglutide monotherapy. If fibrosis does not improve, I would add resmetirom. For case number 2, we have a 56-year-old Hispanic female with past medical history of type 2 diabetes for the past 12 years and has been on a different GLP-1 for the past 5 years. Her BMI is in the overweight range, so 26.6, and her A1C is well controlled for someone with type 2 diabetes at 6.4. And liver stiffness is consistent with F3 fibrosis and significant steatosis. In this patient who has been on a baseline GLP therapy for 5 years with relatively lower BMI and well-controlled diabetes, I would select to start with resmetirom here and then again treat for 1 year and do another assessment for fibrosis. So again, next year we're going to have 2 options, and I think this is a good thing for patients because providers will have to pick one, and then it's key that we assess response to treatment at the 1 year mark and decide if we need combination therapy. So this is the algorithm that we utilize now to monitor patients after we start pharmacologic treatment with resmetirom, and I suspect we'll use the same algorithm with semaglutide. Typically, we do our labs to assess for safety at 3, 6, and 12 months. So this is looking at the liver enzymes, make sure they're not going the wrong direction. There is no evidence of drug-induced liver injury. But then we do an efficacy assessment at the 6 and 12-month mark, and that is done typically with ALT, looking at disease activity. We also measure liver stiffness to assess for fibrosis improvement. And then a key component is to actually quantify liver fat. And we've seen in the Maestro-NASH protocol that when you respond with hepatic fat fraction reduction on MRI-PDFF, so a relative reduction by more than 30%, predicts histologic response, at least with resmetirom. So quantifying liver fat as a way to assess response to treatment is a key component. And then at the 1 year mark, you're going to look at your non-invasive test. If they all improved, you're going to continue. If they worsen, you discontinue for futility. If you don't see significant changes or you see some improvement, but not in all of them, this is when you should consider potentially combination therapy. So I want to spend a few minutes talking about the VeloCure machine by Sonic Insights. This is a new ultrasound-based technology that can measure liver stiffness to determine fibrosis stage, and it can also measure the attenuation and other parameters to quantify liver fat. You can see that it has an ultrasound probe, so you have direct visualization of the liver. You can select the region of interest. There's an AI algorithm that was added to aid inexperienced operators how to localize the liver tissue, and you do these sweeps with the ultrasound, so you can get a 3D vision of the liver. And that's why the volume that you get with VeloCure is about 100 centimeter cube, which is about 30 times larger than the volume you get with the FibroScan machine. So very promising new technology. And VeloCure has been compared to FibroScan using MRI-PDFF as the gold standard for steatosis and using MR elastography as the gold standard for fibrosis. This is a relatively large study done at the University of California in San Diego. And both machines were comparable on measuring liver stiffness and fibrosis. But when we looked at steatosis, we found that VeloCure attenuation coefficient estimate, VeloCure ACE, correlated better with MRI-PDFF. You see that in panel B compared to panel D. So you can see a stepwise increase in the VeloCure attenuation measure for steatosis, and there is not much overlap, whereas with the FibroScan CAP score, there is a stepwise increase, but more overlap. Recently, we have now what we call VDFF, which is Velicure Determined Fat Fraction. So it rhymes with PDFF because it correlates very well with MRI PDFF. So this is a point of care method to quantify liver steatosis. And again, high accuracy and very close to MRI PDFF. And VDFF has other parameters in addition to attenuation. So we are looking at something called the backscatter coefficient. We know that actually having more fat in the liver increases the reflection of the ultrasound signal back towards the probe, and that increases the brightness of the liver. So if you have a bright liver, that indicates that you have more steatosis, and this back scattering can be measured with VDFF, and we also measure the attenuation of the waves because this is impacted by having more steatosis, and then you get a percentage similar to what you get with MRI PDFF. And there was a recent paper that actually validated VDFF in comparison to MRI PDFF. There was a training cohort from 4 centers in North America that shows very nice correlation between VDFF and PDFF. And then there was a validation cohort that was done in a different center showing also very nice correlation. So in the last few minutes, I just want to share with you some other presentations from the liver meeting that discuss some future promising agents. The first agent I wanted to discuss as an example of fibroblast growth factors, FGF21, is efruxifermin, and we had promising data presented with the 2 other FGF21s, pegozafermin and efimosfermin. So this class of medications is looking very promising, especially on fibrosis. So the data from efruxifermin was from the Harmony phase 2b trial. This included patients with MASH without cirrhosis, but with fibrosis. And they're randomized to 2 doses of efruxifermin. And I want you to focus on the high dose, 50 milligrams weekly. And that was compared to placebo. They had a biopsy at baseline showing MASH with fibrosis. They had a biopsy at 24 weeks showing promising results, but then they had the biopsy at 96 weeks, so almost 2 years of treatment. And these are some of the data that were shared at the liver meeting. And what was very encouraging was to see that after 96 weeks of treatment, if you look at the high dose of 50 milligrams weekly of efruxifermin in the dark blue bar, you see that up to 75% of patients had fibrosis improvement by 1 stage. So this is very, very promising. This is what we call a completer analysis or modified intent to treat analysis with paired biopsies. We also saw that up to 1/3 of patients had improvement by 2 fibrosis stages. So imagine taking a patient from F3 fibrosis all the way down to F1 after 96 weeks of treatment. So very encouraging data. And then there was also evidence of a reduction in fibrosis biomarkers. We see a nice reduction in the ELF score that was sustained throughout the 96 weeks. And there was also a reduction in liver stiffness on transient elastography. And it seems that, liver stiffness continues to go down all the way to 96 weeks of treatment. So very encouraging data. And we also shared data with this Venn diagram that looked at 3 fibrosis markers, and we looked at placebo. I wanted to compare placebo to the efruxifermin 50 milligrams. And what we did here, we looked at people that responded on biopsy with fibrosis improvement. We looked at people that responded on liver stiffness, and we looked at people that responded based on the enhanced liver fibrosis test, ELF. And then we wanted to see how many responded on 2 out of the 3 and how many people responded on all 3. And then how many patients did not respond on anything. And if you look at placebo, it was actually 0% of patients that had a response on biopsy, liver stiffness, and ELF. If you look at the efruxifermin high dose, 50 milligrams, almost half the patients had improvement in all three, biopsy, FibroScan, and ELF. And more importantly, 0% of the patients had no improvement in any of these fibrosis biomarkers. So I think we learned that biopsy has issues with sometimes pathologists not agreeing on fibrosis stage or sometimes sampling variability, leading to a one-stage difference in fibrosis. We've learned that liver stiffness has limitations also in terms of determining the stage of fibrosis, and the same applies to ELF. But when you have a patient that is improving on liver biopsy, on liver stiffness, and a serologic biomarker for fibrosis, then you know for sure that there's actually improvement in fibrosis. This is not noise, this is true improvement, and that's why we like to see improvement in all three markers of fibrosis. And then the last compound I want to discuss in this brief update, and again, we had several compounds that I will not have time to go through. I want to spend a few minutes discussing survodutide, which looks also very promising. This is a dual agonist, GLP-1, similar to semaglutide, but also it has a glucagon component. And we know that GLP-1s help with weight loss and diabetes control through different mechanisms, including insulin sensitization and delayed gastric emptying and direct effects on the central nervous system. But we do not believe that GLP-1s have a direct effect on the liver. There are no GLP-1 receptors on the hepatocytes. On the other hand, having the glucagon component in survodutide has direct effects on the liver. It may enhance fatty acid oxidation and affects glucose metabolism. It also affects lipolysis in the adipose tissue, and it's been shown to increase resting energy expenditure, which is another mechanism that can help with weight loss. So having a dual agonist that has both a GLP-1 and glucagon has great potential. And this is the phase 2b trial with survodutide. These data were presented originally at the last AASLD meeting and have been published already in the New England Journal of Medicine. Patients were randomized to 3 doses of survodutide with dose escalation that took up to 24 weeks, and their dose escalated to the maximum dose of 6 milligrams weekly of survodutide versus placebo, and the treatment duration was 48 weeks, so about a year of treatment. All patients had MASH with fibrosis on biopsy, but no cirrhosis. And these are some of the results from that paper showing great improvement in MASH activity. Up to 83% of patients in the survodutide 4.8 milligram weekly achieve improvement in MASH activity. When you look at the paired biopsy results, if you look at all patients, where you count patients that didn't have a second liver biopsy as non-responder, still close to 64% had a response, and this was significantly better than the placebo response at 15%. So very promising data that have been published. And then we had more data at the liver meeting looking at reduction in liver fat. As I mentioned earlier, reducing liver fat is a great surrogate for histologic response. And with the direct effects of glucagon on the liver, we are seeing great results on achieving a relative reduction in liver fat on MRI PDFF. If you look at reduction by 30% or more, this was achieved in about 85% of patients treated with survodutide compared to only 20% in placebo. And then when we moved the bar higher to more than 50%, that was around 75%, and even reducing liver fat by more than 70% from baseline. This was achieved in about 50% of patients on the high doses of survodutide. So it seems that adding the glucagon to the GLP-1 has beneficial effects in terms of more defatting of the liver, and hopefully this will translate into better improvement in MASH resolution rates and fibrosis regression. Data on survodutide effects on liver stiffness were shared also, where we see that with all three doses, there was reduction in the 30% range. And we know that reducing liver stiffness by more than 25 to 30% from baseline has been associated with histologic improvement. And you can see in the placebo arm, there was a slight increase in liver stiffness. And there was also a reduction in the ELF score here by about 0.6 units from baseline. And previous studies showed that reducing ELF by 0.5 or more from baseline is associated with histologic response. So great data with survodutide. So this is my take-home message that we had a historic 2024, and I think 2025 is going to be another amazing year in MASH. I think both resmetirom and semaglutide will have indications for at-risk MASH, which is MASH with F2, F3 fibrosis, and the treatment decision should be personalized based on baseline characteristics, including disease stage, F2 versus F3, and what kind of F3 are we talking about? How close are we to cirrhosis? Also based on comorbidities and baseline BMI and A1C. Previous medications and being exposed to other GLP-1s may also influence how we decide on what medicine to choose for our patients in GI and hepatology and endocrine clinics. And then we have to take into account patient preference. If they have a problem with injection medications, then maybe going on a pill is a big deal for them. So all of these factors will play into our decision which medication we're going to choose first. However, as I mentioned earlier, combination therapy will be beneficial in some patients, and we hope to see a real synergy between resmetirom and semaglutide. And finally, I want to conclude by telling our audience that, I didn't talk about any trials for MASH cirrhosis, patients with F4 fibrosis, but we are expecting three major readouts in 2025 with three different compounds that are being tested in MASH cirrhosis, including belapectin, a combination therapy with semaglutide, cilofexor, and firsocostat. And then the results from the symmetry trial with the furxy-fermin, the FGF21 that I discussed earlier, where we will have a cirrhotic population and biopsy data at 96 weeks. And finally, my last slide is, again, just do something. This was a slide we shared at the liver meeting with two of my friends. We call ourselves now steatologists because we specialize in steatotic liver disease. So these are Dr. Mary Ranella and Mina Bansal, really leading the way in steatology. And again, I hope 2025 will be another historic year for us. So with this, I'm going to conclude and hand it back to my good friend Mike to take us through his slides. Thank you.
Okay, thank you, Naim. As usual, eloquent and complete. Let's go here. Okay, you can see my slide?
Yes.
Yeah.
Perfect. Okay, so again, Naim, you covered a lot of really, really exciting optimistic, realistic data that's going to really help patients. And I want to talk a little bit about the patient side of it and the patient voice, and start by thanking the liver meeting, AASLD 2024 organizing committee for including so many dedicated talks for patients to be able to share their stories and to be able to share concerns and suggestions on things like clinical trial design. And so the three areas that I'm going to share, these are three presentations that were done, or posters in this case, that were done at the liver meeting. And so to give the patient perspective a little bit also. So this first one is really exciting because it's a collaborative approach that took months to put together. I think it's one of the first posters that shares the patient voice. The title is Patient Voice in MASH Initiative, Foundational Principles for the Conduct of Patient-Centric MASH Research. And it was sponsored by PPD, Thermo Fisher Scientific, and it included input from 6 global patient advocacy groups, including the Fatty Liver Alliance, ELPA, Prometheus, Liver Education Advocates, who were previously known as NASH Knowledge, GLI, and Amigos del Hígado AC. I had the privilege and the honor of being the lead author on this poster, and really, really proud of the work that was done, and I'm going to share with you what's on the screen here in the output. So the project brought together 6 global patient advocacy leaders to really reimagine how clinical trials for MASH are designed and delivered, and focusing on what really matters from the patient perspective. The outcome from the initiative is a set of, you can see them here on the screen, these uh, uh, foundational principles that I'm going to share them with you. So the first one is about transparency, and it was about clear and honest communication with participants from the first day that they're involved with the clinical study, like explaining how placebos are used in that study, when they'll have access, if they will have access to active treatments. The second is about whole person focus and addressing not just the medical, but also the emotional and practical needs of the participants. So that would include being cognizant of the evolving circumstances of any of the patients that have liver disease and what they go through on a daily basis, the struggles that they have. The third one is important too. It's about patients as partners, and that's involving patients as collaborators in the trial process rather than just subjects. Sometimes patients feel like they're just a number, and the doctors see them as a dot on a graph or part of a data set, and they're really people, and they want to be respected that way. The fourth is about family and caregiver awareness and recognizing the crucial role that families play, especially as the disease progresses. And the family members are the ones that are coming with them to all these appointments and seeing them. And so we want to make sure that that they're a part of it also. And the last one is about responsiveness to patient needs, and that's regularly collecting feedback during trials and acting on it immediately to improve the patient experience and to make sure that patients stay compliant and on the treatments that they're on. So one point I like to emphasize here is how this approach puts patients at the center of the conversation. And what makes this especially powerful is the attention to diversity and inclusion. And trials really need to be designed to consider the cultural and socioeconomic challenges that patients have. So the ultimate goal is to make MASH trials not only more accessible, but also more impactful for everyone that's involved. And it isn't just about the data, although as Naim pointed out over the last few minutes, the data is very, very important. It's also about fostering the trust and respect and real-world solutions for a disease that's on the rise globally. I'll end here by saying that this poster is a call to action for the research community. It's really a roadmap for how to listen to patients, how to learn from their experiences, and ultimately accelerate progress in treating MASH. Next, I want to share, and this is really a shout out to Madrigal because I think they did an incredible job. At the AASLD, they had over 90 people all in one room. These long tables were set up, and it was really to set up an environment where we can have discussions and open communications in a safe environment. And we had patients and caregivers, we had advocacy leaders, people from Madrigal itself, including the president who was there. And it was an opportunity to have this organization listen and to have patients and all of these other partners have a chance to discuss what they felt was really, really important. And so this was all shared in a presentation called Community Conversations. And there was 2 main pillars of information that were shared back. The first is about the human burden of MASH, NASH MASH. And it was really shared by the patients in the room that although we often hear that liver disease, MASH, MASLD, they're silent diseases, a lot of patients experience a lot of events that need to be really respected too. And that includes being frustrated, stigmatized often. They feel stigmatized even at the doctor level sometimes. And probably most common, exhaustion and just tired and the fatigue, I guess, that goes into all of what it is about being involved in this illness, because it is taking a toll on people. And the belief in the room was that the MASH landscape, it's really kind of poorly understood even by healthcare practitioners, and that patients themselves really need clearer information about what MASH is and how they can manage it better. One of the things that they found was very advantageous was sharing their patient stories with their healthcare practitioners and with other partners in care that they have, because it helps to describe some of the urgency and some of the help that they need. And one of the overlying themes, too, was about the importance of continuing to focus on non-invasive testing. Biopsies were not appreciated, are not appreciated, and from a patient perspective, they would love it if they never had to have a biopsy again. Now, talking about clinical trials, which is really the theme of the three presentations that I'm sharing with you, the idea in the room, the thoughts in the room is that patients need to be sought out with regard to early input in clinical trial design so that they can share what their thoughts are and their frustrations and their challenges are. Again, moving away from biopsy, the importance of diversity and inclusion in clinical trials, and that would be everything from the underserved communities. It could be other ethnic diversity groups, both rural and urban. And one of the other things that was brought up specifically was the importance of including pediatrics in MASH, because there is a lot of data now showing that it's really starting off much earlier than it used to. So the third area that I wanted to share, and this presentation was part of this community conversation, is a new group that was formed, and it's called PETAL, and it stands for Patient Engagement and Drug Development Leading Through Example. And this is very innovative. It was launched September this year at the Liver Forum for Collaborative Research in the Liver Forum 17 session. And the chairs are Rose Salati, Henry Chang, Sayer Khan, and myself. And the point here is to make sure that patients' perspectives are taken into account in early clinical design. And I'm going to share with you what all that means. And taking into account the current landscape of patient engagement. And what was an important point, too, is including regulators into the touch points with patients as well. All of these organizations, and you can see here the interdisciplinary cross-functional roles from industry to patient groups to the Foundation for the NIH to FDA, all of these groups working together to try to make sure that clinical trials take the patient perspective into consideration before they move forward. And a note about Liver Forum. So this is a working group under Liver Forum, which is an amazing organization meeting throughout the year with a number of working groups, and we're the most recent one. And you can see on the right the types of individuals that are part of this, and it is really a multi-stakeholder opportunity to have open dialogue and discussions that talks about barriers, how to prioritize research, identify solutions, and really focus on improving research in the MASH area. And I wanted to note here this definition that I think was the best one that I found for Patient-Centered Outcomes Research Institute, PCORI. Patient engagement is the meaningful involvement of patients, caregivers, and the healthcare community at large throughout the research process, from planning and design to implementation and dissemination of results. This engagement ensures that the perspectives and experiences of patients drive research priorities, study design, and outcomes. And that's really important. So let's take a look at some of this. So as presented at the AASLD as well, these slides, the same data. This is patient engagement examples that are already happening. So real world symptom tracking, lifestyle integration, including these are very important, the mental health and behavioral support metrics that are really incredibly important for patients. The invasive procedure reduction, or focusing on non-invasive procedures, which we talked about already today a number of times, and diversity in MASH trials. So when we're looking at the patient engagement, some strategies, this is what we're going to be working on in this new group called PETAL. So it's forming patient steering committees and advisory boards that are going to include patients, making sure that the trial materials and processes are patient-friendly and the patients can really understand them. And this is also from a cultural perspective. There are a lot of new tools that are available now, health related tools and technologies, and incorporating them into the patient experience and how to best do that, recognizing and addressing some of the challenges with health literacy so that patients know what they're getting into before they agree to the clinical studies. And also, it was important to about sharing trial results too, before, during, after, any way that the organizations can do that from industry perspective. So Chris Frates from Madrigal presented these three challenges and opportunities. The first one is just recognizing that there is no, at the current time, the standardized processes for collecting patient input, and we need to create some alignment around toolkits that might be able to help with that across all the industries and the clinical trials that are starting. The second one is to recognize that not organizations are all in the same point. So some of the smaller organizations may not actually have dedicated people that focus on patient advocacy functions. And so if we can build this inclusive understanding of what patient advocacy is, it can be something that can be rolled out and applied across pharma. And the third is a recognition that the patient voice is growing, getting louder, and patients and patient advocates need opportunities to be funded to be able to go to some of these conferences like the AASLD. And so if we can establish grants and scholarships, that's something that would be really appreciated and would benefit everybody. And my last slide is one of the slides that Henry Chang from Fatty Liver Foundation shared, and it was about diversity action plans. And specifically, this is about diversity and enrollment in trying to consider the real world barriers like language, transportation to and from, the updates that they have to, the meetings that they have to go to, the patients to be able to participate in the clinical studies, making sure that all the educational materials and consent forms are all culturally appropriate and language appropriate, and we consider even things like childcare, which are important, and all of these things are really important for patients. So that's what I wanted to share, and those are the three things that, from the patient perspective. So today you've had an opportunity to hear from Naim from the science side and from myself from the perspective of the patients. So Naim, what do you think? It's a good mix, right?
Yeah, I agree. And I'm very impressed with all these good things that you are doing because at the end of the day, what we've shown that we have promising data with resmetirom and semaglutide, but the delta improvement on fibrosis leaves a lot of room for other innovative approaches and new medications. And we need to take these medications to the finish line. And it is becoming a little bit harder now to find patients that are GLP-1 naive, that didn't change the dose for the
Right.
GLP-1 for 90 days or 180 days. Now, what you guys are doing is really remarkable. So I want to applaud you and the team. And hopefully this will streamline the recruitment process into trials and help expedite the timelines for the sponsors.
Yeah, and I want to point out that this is a collaborative, all of these are collaborative efforts that are happening across all of the patient advocacy groups and industry. The pedal group is growing exponentially, and we've already had a couple meetings as teams. And so if other organizations watching this want to become part of that, we would love to have you as well. Naeem, I wanted to ask you, you're one of the busiest clinical research teams, and you have an outstanding, I know them quite well, group, the experts that are recruiting every day. What are the patients saying that they're coming in? They're getting this opportunity now to try out all of these latest therapies, and it's just so, so exciting. And I know you're excited. You're not smiling enough, I told you, but this is a really big time here. So where are we at right now? How are they feeling about all this?
Yeah, I mean, I think the patients are excited about having FDA approved medications. I think this is a big deal for them because for years they heard like just lifestyle and try to lose weight, which is still a big component of everything we do. But to have, the ability to treat with the medicine is a big deal for many of them. And then when we tell them we also have clinical trials and you have access to medications that we cannot prescribe because they're not FDA approved yet, when you explain to them the stage of the study, whether it's a phase 2 versus versus phase 3. We give them all the details related to the placebo rate and the potential adverse events and the potential benefits to them and how they are helping medicine and science and potentially millions of people down the line by participating in a clinical trial. We tell them that, the trial is absolutely for free for them, that we are not having to go through insurance. There will be no deductibles or copays or anything. In fact, they get a stipend for every visit they come for research. I think many patients find clinical trials appealing, although they're not for everyone. And we have patients that decide to go the standard of care route, and that's perfectly fine. One of the things with clinical trials, we have usually a long list of inclusion and exclusion criteria. At the end of the day, even when patients are interested, unfortunately, sometimes we are not able to qualify them. One of the biggest reasons for screen failing in clinical trials is not meeting the criteria on liver biopsy. And I really hope that in 2025, we're going to witness some major developments where the FDA will provide us with an alternative pathway for accelerated approval that does not require two liver biopsies to assess for efficacy. So that could be one major news in 2025.
Yeah, and things are progressing like at an outstanding rate with regard to the non-invasive tests. There's a lot of biomarker options available, and as you said, there's a lot of scanning technologies that are available, which are all non-invasive. So hopefully we can come to some agreement with the FDA where the drugs will be approved and the clinical trials will be approved without having to do that too.
Right.
And what would you recommend for the primary care uh, physicians that might be and other partners that might be watching this right now? How can they get their patients involved more in clinical trials?
I would say again, implementing the three S's in their practice is a big deal. So please screen if you find the steatotic liver disease, try to get to the stage, whether you do it in your clinic or you refer out, and just realize that we can start them on treatment if they have MASH with F2, F3. So keep this message in mind. But when it comes to patients that have more advanced disease, F2 fibrosis or higher, just realize that you can go to clinicaltrials.gov and you can actually research the trials that are available, and you can see which ones are available in your city or your region, and you can share this with the patients. Make sure you also discuss with the local providers. They may have access to the clinical trials, and just make it kind of a habit to offer clinical trials to patients as one way to provide excellent clinical care. I always tell my patients the care you get in clinical trials is superior to any care you get in a standard of care clinic, because you have more visits, you have more nutrition counseling, you have more blood tests, MRIs, things that you may not get routinely, and it's all done for free. So knowing about the trials, sometimes also PCPs think that maybe we can treat MASH, but cirrhosis, it's too late. So if they diagnose someone with cirrhosis, say your disease is too advanced. And this is really not true, because we have several trials for MASH cirrhosis. I shared some of the readouts for next year, and if these are positive, we will have all of them in phase 3 trials, hopefully. And today I can tell you at some of our centers, we have 4 MASH cirrhosis trials open for enrollment. So this is another key message.
Okay, so I wanted to follow up a little bit on this is something that we didn't talk about yet, but um, the MASLD is really probably about 40%, let's say, of the population now, give or take, right? Unless we actually test every person in the world, we won't know exactly. So, are you, as an expert, confident that the patients can be followed up to what point? So they don't have F2, 3, 4 or advanced. For sure, they can stay with the primary care for that part, right? And so maybe you can comment on that, but also what happens at F2, F3, and when would they refer in best scenario from your perspective?
I mean, we do have the algorithms by AGA, ASLD, ADA, ACE. They all agree that in primary care, maybe starting with the FIB4 index is a good idea. Despite the limitations, I think it's a step forward. So calculating a FIB4, if it's less than 1.3, I think doing it every other year is reasonable to monitor for progression. And then if it's more than 1.3, this is when you need to either obtain transient elastography or utilize the Velacure machine, or maybe do a serologic test for fibrosis. And this can be done also with the subspecialist. So FIB4 is a good way in primary care. I think we need to understand the caveats, and maybe in diabetics, lowering the FIB4 to 1.0 instead of 1.3 is a better way, so we don't miss patients that may qualify for treatment. Also realizing that in patients older than 65, we need to increase the cut point from 1.3 to 2.0. So there are some nuances to that, but I think that would be one way to do it. And for the patients that are at low risk of having significant or advanced fibrosis, I think repeating the non-invasive testing every 2 years is reasonable, and then you refer if you see an increase. Of course, if you are in a clinic and you have access to a Velacure machine or transient elastography machine, you can just do it as your screening test, because you can diagnose steatotic liver disease based on the attenuation or the VDFF, and then you can also determine if they have significant fibrosis. So this will be kind of the screen and stage steps in one test. And then you should refer patients that have steatotic liver disease with F2 fibrosis or higher.
Yeah, I would thank you for that. I would also just reiterate the fact that the lifestyle management piece, even with Rezdiffra being approved, is part of that. So the diet and exercise component is still important anyway. And we can, as patients, make a difference in the amount of liver fat by increasing our output of energy, reducing weight, be it 5 to 10% or more, depending on how severe it is. But there was a really great session at AASLD, just to wind it up here, also with lifestyle management, and it was a patient streamed. It was live, but it was a patient focused event, and the room was packed right to the standing room only at the back. So there is definitely an interest in doing what we can even before medications, if it's possible, but recognizing that they'll have to maintain this lifestyle with or without medication. So
And that's our goal, honestly. If we can manage the disease with lifestyle, I think that's what we all want. It's just we want to have other options when we are not successful with the lifestyle.
yeah. I want to thank Sonic Insights for sponsoring this, setting this up with my good friend Naim, and I would savor any opportunity to have a discussion about MASH with you, and for those that came today, thank you for coming and watching, and wishing you and your families a happy and healthy holiday season and a fantastic 2025 ahead.